Welcome to this webinar brought to you by SBK Healthcare and supported by Missie Tumor Onbekend and Sarah Jennifer Knott Foundation. The webinar is part of the World Cup Awareness Week, and further information can be found on this at www.worldcupawareness.org. To find out more about further educational webinars and online forums, please do visit our website www.sbk-healthcare.co.uk. So in this webinar, you'll be hearing from Dr. Marieke Vollebergh from the Netherlands Cancer Institute, Professor Dr. Alwin Krämer from the German Cancer Research Centre, and Dr. Mitchell from the Acute Oncology and CUP Services at the Central Manchester Foundation Trust in the UK. They will be presenting on clinical CUP diagnostics and care pathways, differences across Europe.
Thank you, Sarah, and hello everyone. I would like to extend a warm welcome for everyone joining us today for the second webinar of this year's World Cup Awareness Week. I'll be your host today, representing Missie Tumor Onbekend, the CUP patient and advocacy organization in the Netherlands. And together with our fellow patient advocates from the SJK Foundation in Ireland, we are organizing this year's World Awareness Week with the objective of raising awareness and also hearing from researchers and clinicians across the world who are leading the way in improvements for CUP patients. And I would like to remind you that you can always visit our website, worldcupawarenessweek.org, for all information regarding cancer renown primary and also the programs for this week's lunchtime webinars. And I would also like to say thank you to this year's sponsors, being Roche, and also the supporters from testing.targetedtreatment.org. And this year, 2022, marks the second year we are organizing the World Cup Awareness Week. And even though in the era of precision oncology, there's much more awareness being raised about cancer renown primary, there are still many patients that need and count on our support. For example, in finding detailed patient information in their own language, how to access advanced diagnostics, and for example, information about which clinical trials would be suitable for CUP patients. And this year's Awareness Week focuses on that theme, the patient journey. And today we will have three oncologists, Dr. Vollebergh, Professor Krämer, and Dr. Mitchell, who will now briefly turn on their cameras. Great. And they will be sharing with us how the CUP patient pathway, the patient journey in each of their countries is organized so that more CUP patients can access care. So now I would like to introduce our first speaker, Dr. Marieke Vollebergh. She's an internist oncologist at the Netherlands Cancer Center at the Antonie van Leeuwenhoek Hospital. And she's also the principal investigator on a new national Dutch protocol on improving CUP diagnostics. The floor is yours, Marieke.
So thank you, Renita, for these kind words. And thank you for giving me this opportunity to tell you something about our care pathway, which had to undergo big renovations in the last year, actually. So next slide, please. I had a little bit of a problem, so I'm asking Emma for my next slide. So I have nothing to disclose. I thought it was good to know. Next slide. So why we had to undergo big renovations is because whole genome sequencing was introduced into our standard of care for patients with CUP in the Netherlands in April of 2021. And it became so part of the basic healthcare insurance, but it's not just easily done. So we have to meet certain criteria. And those criteria are pretty specific. And in that sense, we had to change the diagnostic routes. And we really made a new care pathway for that. Next slide, please. So how did this come about that whole genome sequencing became part of our standard of care is actually because our Netherlands Comprehensive Cancer Organization, which is a big cancer organization, which registers all data of newly diagnosed patients with cancers in the Netherlands. They have done this for a really long time, and they register basic patient characteristics, but also pathology. So a lot of data is in there, and you can see how you've been doing in the last couple of years. And that's what they actually did for patients with CUP in April 2020, and they wrote a report on it. Next slide, please. And what that report showed is that we actually didn't do so well. We didn't do so well for steadily years in a row. So what I depicted here is on the left Years of diagnosis depicted by number of patients with CUP. Light blue is patients that got treatment, and dark blue is patients that did not receive any treatment. And what you see is that over the years, the same number of patients actually do not receive treatment, and that is more than 2/3 of them. On the right, what you see is how many investigations we need to actually conclude that we don't know where the tumor is coming from. And what you see is that it's set out by performance score. So the better the patient is doing, the more imaging we're doing. And on average, that's 5 investigations we do per patient, but the range is pretty big. It's 1 to 17. And you can imagine what that means for how long it takes, how long the diagnostic route actually takes. Next slide, please. So what happened is that a lot of people wanted to change this around and make sure that the perspective for patients with CUP would become better. And I think the biggest among them is our patient advocacy, for which we are really, really happy that they're there, including Juanita. And they, together with a lot of people, but I think namely our healthcare insurance companies and a little bit of politics, made sure that the whole genome sequencing was included in the standard of care. Next slide, please. So we had to develop a new care pathway for this, and I think that care pathway serves 3 goals. One of the goals that we of course set, and I think you recognize it, is that it's not totally clear who does what on diagnostics. So we wanted to standardize it, and what we most of all wanted to do is shorten it. Next goal that we next goal that we wanted to make sure that happened is that every patient in the Netherlands would have access to the whole genome sequencing. And we have a Dutch term for it. I thought I would share it with you. We call that zip code medicine, and that's what you want to prevent, so that a patient in Amsterdam would be treated different than the north or the south of the Netherlands. So that's what the protocol should prevent, actually. And the last goal that we hope to obtain is that we can collect data on these patients and the new technique together. And so for that, we made a new care pathway, but we put it into a sort of protocol. And we dubbed that the DI-CUP protocol. Next slide. So for that to understand, you need to know what the conditions are for the whole genome sequencing. And there are actually 2. So what the healthcare insurance company said is that the indication that the whole genome sequencing is necessary should be set by a CUP expert center. So in short, it means that the CUP expert center should agree with the other hospital that indeed there is a patient with CUP, and certain criteria were set for that. Sort of in and exclusion criteria, which are really basic, and you can actually say that they are based on whether a patient can actually undergo treatment, yes or no. In case of no, then the whole genome sequencing does not add. The other criterion that was set is that the results of the whole genome sequencing should be discussed in a specific molecular tumor board. And that specific MTB is set in our university hospitals and in my own comprehensive cancer center. Next slide, please. So this, I'm going to try to walk you through a lot of diagrams, which is a little bit, a lot of text on the slides, but I hope I can walk you through it. So what happens is in the diagnostic workup of a patient who comes in with the suspicion of having a CUP, what should be done? Well, basic laboratory results, a CT, it can be a CT, a normal CT scan or a PET CT, we didn't define that. And we should have normal pathology, so normal immunohistochemistry. And actually that's it. More is not necessary unless you really think it will add something, but it should not postpone or make the trajectory longer. If you have these results, you can have either 2 outcomes, and I'm going to focus on the right because of the time. So either you have an outcome in which you actually know what kind of treatment you want to start, or you have a provisional CUP. And we stole that nice term from the NICE guidelines from years ago. And if it's a provisional CUP, then the case will be sent to a CUP expert center, and they will review the case on paper. or digitally, or whatever that center set up. And that's important because we want to report back whether we agree or not within 2 working days. So to speed things up. Next slide, please. So let's say that you agree. It's in accordance with the center that sent the patient's case. If you're not in accordance, then you sort of give advice on what kind of diagnostics you would have done anyway. But if you're in accordance, you think it's actually a CUP patient, what then should be done? I'm gonna move to the left. You see that then a fresh frozen biopsy should be sent for whole genome sequencing. And simultaneously, the normal material, so the old-fashioned FFPE, will be sent to the pathologist of the CUP center, who is experienced in patients with CUP. And also simultaneously, what happens is that the clinical data, including the imaging, will be sent to a medical oncologist of the CUP expert panel. In green, you see what happens if the whole genome sequencing fails. We also have extensive next generation sequencing panels, but I'm not going into that today. So if all the data then comes in at the CUP Expert Center, what then happens is that it's being discussed in a multidisciplinary team. And what they discuss is the revision of the pathology, and maybe extra immunohistochemistry has been done or not, but that has been taken into account. The clinical data is taken into account, and the MTB has looked at the whole genome sequencing results and also gives a conclusion for that. And all the information coming out of these investigations will be sort of put next to each other, and the MDT will conclude something of it. And it could be that they conclude that there's actually a primary tumor found, or maybe there's something else. I'll go into that in detail later. The summary of that conclusion will be given back to the patient by the medical oncologist of the expert panel. And it will also be given back to the treating medical oncologist in the hospital close by to that patient. And that treating medical oncologist will then go will speak to his or her patient, and they will together decide what should be the next step in treatment. Next slide, please. Oh, sorry, you can click this on. I discussed the whole thing. I cut it up to make it a little bit more easy to go on, but I hope everybody followed it. So what can be the possible outcomes of that MDT discussion and the whole genome sequencing is what our whole genome sequencing also does is it gives a new analysis. We call that the CUP analysis, and that paper is in press. And it uses 3 genomic features to make a classifier to say what kind of the tumor of the CUP patient resembles the most. So what it does is we have in a database whole genome sequencing results of 4,500 tumor samples, of which you know the primary origin. And then using those genomic features, you sort of look for resemblance, and you get a likelihood for resemblance. And sometimes it's really high, and sometimes you get 2 kind of tumors, but together with your pathology, you can then narrow it down to 1 kind. That's the best you can hope for. If that doesn't happen, then you, of course, have results on actionable molecular variants that can help you for potential new treatment options. Next slide, please. So the results of that MDT can be either, okay, we have found your primary tumor and you can treat accordingly, or we didn't find it, but we have an interesting molecular target. And then patient can maybe be treated in a study. I'm not going into the Capisco study because I think Alwin will go into that, but in the Netherlands, we also have the DRUG study. I would like to tell you a little bit about that. Next slide, please. And that's the drug rediscovery protocol. And what it does, I find really cool, is that we, of course, know actionable variants, and we have drugs available for that, anti-cancer drugs, but it's always for certain tumor types in which it has been shown benefit. And what this study does is they say, okay, we're going to try to identify a different cohort of patients with the same molecular variant, but see whether the anti-cancer drugs that we usually use is also applicable here. So you're going to treat outside of the approved label, but in the same specific molecular variant and in a specific tumor type to be able to study what you're doing. And if you want to be included in this study, what should be done is that you have already received all your standard therapy or were unable to get it. And I think for patients with CAP, nobody knows what the standard therapy should really be. So this could actually be a really good way to see whether they benefit from these actionable molecular variants. Next slide, please. Well, I think I've talked really fast, but in conclusion, what I tried to show you is that we had quite a big renovation going on, and it was because the whole genome sequencing came into our standard of care, which made it we really had to do a fast track on our care system, and that resulted in now CUP expert centers. And what we try to do is make it accessible for the whole of the Netherlands. There are a lot of clarity still, because if you're now going to ask me, so, okay, how good is that whole genome sequencing for your patients? How do they benefit? Then the actual question is, the actual answer is that we don't know yet. So we don't know yet how many patients actually have a targetable option, whether the quality of life changes, whether ultimately, hopefully, the overall survival gets better. And that's what we hope to do with her prospective data collection. I have on the next slides the acknowledgements, but I won't go into that, but a lot of people were involved with it. So a lot of people from the pathology and their society and our medical oncology society, the people who do the whole genome sequencing, Juanita and our patient advocacy, the health insurance companies, and what we call IKNL, so that's the Netherlands Cancer Organization. And I think that's what I wanted to tell you.
So hello, everybody. My name is Alwin Krämer. First of all, I would like to thank the organizers for inviting me and to give the view from the German side here on what's going on with regard to diagnostics and care pathways. These are my declarations of interest. And who are we? In terms of CUP, we are a CUP clinical cancer research program based in Heidelberg as a part of the University of Heidelberg and also as a part of the German Cancer Research Center and the National Center for Tumor Diseases in Heidelberg. We do see around 100 new CUP patients per year. And in contrast to the kind of comfortable situation in the Netherlands right now, next generation sequencing is not standard of care yet in Germany, and therefore we have to rely on other options and tools to serve patients with CUP and also to provide them with that opportunity. To do so, one option and one important option actually is to include patients into clinical trials, and we have right now 3 trials running in the indication CUP in Germany. The first is Copisco trial. The second one has started right now. It's called K2 CUPS, and the third one is CheckUp. And I would like to go into detail with those 3 studies. First, the Copisco trial. Many of you might know already. It is a huge endeavor, an international trial, recruiting in total more than 600 patients, and we are almost done yet. That's the good part of the story. And it's a randomized trial that randomizes patients between standard of care, platinum-based chemotherapy, and an experimental arm that right now consists out of 12 strata, 12 strata, depending on the results of next generation sequencing that is performed at the time of study entry. And those patients then that are randomized into the experimental arm then receive targeted treatment according to the outcome of this next generation sequencing. We are not done yet, but almost. So most patients have been included into the trial already, but therefore we do not have results yet. They are expected to be available approximately 1 year from now. But there are quite a few important, in our eyes, in-study learnings already. And one is the standardization of diagnostic care. What we have learned during the course of the study is that we have to fight a large amount of eligibility failures during the screening period of the trial. So we had more than 50% of screen failures, and about 1/3 of those were due to an incorrect diagnosis of CUP. And this is, on the one hand, obviously a problem for the homogeneity of the trial itself, because we rely on including real CUP patients into the trial. But on the other hand, obviously also a big problem for the patients, because if the diagnosis is not correct, the treatment isn't either. So for that reason, we have developed, based on these screening failures, improved diagnostic algorithms for the diagnosis, for the correct diagnosis of patients with CUP syndrome. And based on those improved algorithms, we have now developed an updated version of the CUP ESMO guidelines for diagnosis, treatment, and follow-up. In addition to that, we have developed the first WHO classification of CUP, something that is in place for most other tumor entities for ages already, and this is now in place for CUP as well. So we think this is quite an advantage to have standardized diagnostic algorithms to make the correct diagnosis in patients with CUP. From that, we have also learned, this was known before, but we have refined that as well. One of the favorable CUP subgroups, which is called single-site or oligometastatic CUP. This is important because in this case, the treatment completely differs from all other CUP patients. No, at least not in the first-line setting, no next-generation sequencing, no targeted treatment, no chemotherapy is necessary here, because when those patients are treated with surgery and or radiation of the single or oligometastatic manifestations of CUP, then the prognosis of those patients is, as compared to the other CUP patients, a lot better. And therefore, the first-line treatment in this group is independent from next-generation sequencing, independent from chemo or targeted treatment, surgery and or irradiation only. Another important in-study learning is the advent of liquid biopsies. As it has been told in the previous talk, next-generation sequencing usually relies on tumor tissue, not only in CUP, but also in other types of malignancies. But especially in CUP, this might be a problem because the biopsy tissue in CUP patients is often very, very limited. And there are not so few cases where sequencing cannot be performed because there is not sufficient amounts of tissue available. And therefore, liquid biopsy, so drawing a little bit of blood and doing next generation sequencing based on that, is really helpful. It is also helpful because of tumor molecular heterogeneity. So one biopsy site, so one metastasis, might harbor different mutations as compared to other sites. And when you then take blood, you have all of them in this blood sample. And during the CUPISCO trial, we have evolved from being able to sequence 62 genes only within the blood to now being able to sequence more than 300 genes and also have information on other important factors like microsatellite instability, tumor mutational burden, and so on. So another really advanced that has evolved during the course of CUPISCO. The K2-CUPS trial is a diagnostic trial where we, for the first time, at least in Germany, don't rely on panel sequencing, but do whole genome sequencing plus RNA sequencing, followed by a molecular tumor board. We will in total include 100 patients into the trial. It's an international one in which patients from Sweden, Japan, and Germany will be included. And the last trial that I would like to briefly allude to is the checkup trial. It's an immunotherapy trial in patients with previously treated and chemo-resistant CAP, and these patients do receive nivolumab and ipilimumab, and at study entry, all those patients also do receive next-generation sequencing in the form of panel sequencing again. So to sum that up, one important source of being able to provide patients with next-generation sequencing and targeted treatment, at least in Germany, is inclusion into clinical trials. In addition to that, we have here in Heidelberg, as a single institution, the option to sequence specifically patients with CAP, because there is a single institution agreement with health insurance companies between Heidelberg, so the Department of Pathology of the University of Heidelberg, and those health insurance companies. After the sequencing, we do need to do, and this is also very good that it is the case, a molecular tumor board, and this molecular tumor board comes up with a treatment recommendation, but then we have to case by case apply for off-label treatment that is then hopefully covered by health insurances. Another program also based in Heidelberg is called the Master Program. It runs at the National Center for Tumor Diseases, NCT, here in Heidelberg. And this is whole genome or whole exome sequencing that is not restricted to a specific tumor entity, but that is good for all patients with rare cancer entities. And among those, there is also CAP, and in a publication, in the first one that appeared last year, 52 patients with CAP syndrome have been included here as well. And as you can see, the registration number and the case numbers that are sequenced within that program is increasing. And we have managed to give almost 1,000 treatment recommendations based on this program to patients with rare cancer entities. But again, then we rely on case-by-case applications for insurance coverage of the recommended treatments. And the last option, to be able to provide next-generation sequencing to patients with CAP and other tumor entities, is something that is called Centers for Personalized Medicine. This is provided by 4 universities, all based in Baden-Württemberg, which is one of the federal states in Germany, University of Heidelberg, Tübingen, Ulm, and Freiburg. And within those centers, next-generation sequencing approaches are paid for the patient. But this is, again, good only for those places. Samples are sequenced, and then a molecular tumor board recommendation is spoken out. But again, we then have to apply for off-label treatment coverage by the health insurance. Finally, I would like to advertise and also let you know that we now, for I think 2 or 3 years already, have a CAP support group in Germany as well that is really flourishing. Many patients approach the support group, and many patients that we see here made contact via this support group now in Germany available as well. To conclude, there is significant variation in access to CAP services in general and to next-generation sequencing options across Germany. Tumor sequencing is provided at several levels, but with a wide variation within clinical trials, foremost within clinical programs, and also within federal states in Germany. Treatment coverage by health insurances is becoming increasingly difficult here in Germany, despite the availability of sequencing data, despite molecular tumor boards are in place in many places in Germany, and despite increasing amounts of data that justify such treatments. So, and as a final and most important conclusion, targeted treatment approvals and additional clinical trials are certainly required and will be helpful in dealing with this problem. These are my acknowledgements. So many people involved here, both in Heidelberg and at institutions outside of Heidelberg, that participate in this endeavor and that also participate in the clinical trials that I've mentioned. And these are the institutions that do, among others, and among state money, pay for this endeavor. Thanks very much for your attention.
Thank you, Alwin, for sharing perspectives on the patient journey for German CUP patients and also highlighting several clinical trials. I think during the Q&A, we will also dive deeper into the options for CUP patients outside of trials. And also thank you for highlighting the German CUP patient organization. I think as organizers, next year we should try to get them involved in the World Cup Awareness Week. And then over to our third speaker of today, Dr. Claire Mitchell. Claire is a consultant in medical oncology and the clinical lead for acute oncology and CUP services at the Christie Trust, where she's overseeing service development of acute oncology services and training in the region. The floor is yours.
Hello, thank you. Well, thank you for inviting me to speak today. As was kind of introduced there, my name is Claire Mitchell. I'm a medical oncology consultant at the Christie in Manchester. I think probably the first thing to say, it's already been touched on really, is that certainly within England and in the UK, there's still a lot of variation in terms of our services, and they're still evolving and developing as we go. So I guess I'm presenting the picture that it is perhaps locally for me in Manchester, but there are other models within England which work very well, and I think it's one of those things that not one size fits all. So it's just giving a flavour perhaps of what we have here. So next slide, please. Just a little bit of background. So, I mean, we're all aware how challenging this group of patients are. It's a very heterogeneous group of tumours, and often these patients will have gone through various diagnostic test in order to try and determine a diagnosis, and often CUP is almost a diagnosis of exclusion when there's almost seen as a failure to identify the primary site. In the UK, it counts for about 2% of new cancer diagnoses and is the 15th most common cancer that we see. But there has been a reduction in the incidence over the last decade, and that's probably due to perhaps our diagnostics getting a bit better, but also us gaining probably a better understanding of what CUP is and those definitions and algorithms like it's just been presented by Alwin. And we're perhaps becoming a little bit more confident when we're seeing these patients about actually classifying them slightly differently than what we did perhaps 10 years ago. Next slide. So the background to our services, just to give a little bit of history, really has developed in terms of CUP services over the last 12 years, and it's probably started to be established with the development of the NICE guidelines back in 2010, which is now, it's obviously quite a long time ago now. But our NICE guidelines here in England essentially laid out what CUP services should look like in a way, what they should comprise of. It set a model for a CUP MDT, which needed to consist of an oncologist, a pathologist, a radiologist, specialist nurses, and palliative care support within that MDT, and talked also about diagnostics and touched a little bit on treatment, but not so much. It was quite generic in terms of what we did in terms of managing our patients. But it certainly laid out some guidance and put a pressure, I guess, on trust to start to develop these services and identify the need for these services. That was then probably taken forward through our quality surveillance programs that we have here in England. And this essentially sets standards for what was expected for cancer of unknown primary. So again, really setting standards for what services should look like and what they should consist of, and gave outcomes in terms of what patients should expect during that pathway. In terms of our clinical practice, really probably relates to, again, documents that have already been touched on, such as ESMO guidance. And so really, there's a lot of similarity, I think, in terms of the diagnostics across these documents. And generally, there's no outliers, I think, within them in terms of what we should be doing. But how do we deliver that diagnostics, and what is that pathway like for our patients? Next slide. The one thing that the NICE guidance did do is that it set out some definitions, and we commonly still use these definitions, and they're quite integral, I think, to the pathway that we have. So our patients will often start off as being labelled as malignancy of undefined origin. So these are patients where we have detected or identified metastatic cancer, but it's not really clear where it's come from, and that's really on initial imaging, perhaps, for example, ultrasound or plain X-ray, or clinically. They then go a series of investigations, usually initial investigations that would determine radiology, like CT scan or PET-CT, where they might be labelled as a provisional CUP, and then they move on to confirmed CUP if, after specialist review, no primary is still detected. And so this is essentially a spectrum, I suppose, of diagnosis across a time frame. Next slide, please. But there are several challenges over this diagnostic pathway, some of which we've already hopefully addressed or are in the process of addressing, some of which still remain. And I think at each point a patient will obviously face a challenge, and I think clinicians face challenges in dealing with these patients. We often see our patients presenting with vague, very maybe non-specific symptoms. That can mean in primary care, it can be quite difficult for GPs to perhaps identify which patients do need referral onwards. Initially, we will have 2-week wait pathways, which were really very set up for specific symptoms. And so when you've got a vague symptom, there's perhaps not a pathway which is obvious to refer to. And I'll come on to how that's perhaps being addressed through the development of rapid diagnostic centres within England. Tests then often are performed, but if there's no specific pathway, they might be not done urgently. This can lead to delay in the booking, but also in the reporting, and then that potentially causes further delay in actually the diagnosis. And because there's an uncertainty about what the diagnosis is, that obviously is then perhaps relayed to the patient, and then patients obviously struggle what this means in terms of their management, and then potentially lack the support that they will need at this time. Patients often will go through several MDTs. Again, this is changing since the development of CUP MDTs, but we will still see a lot of patients go through site-specific MDTs, perhaps 3 or 4, before they actually are then referred onto a CUP service. So perhaps it's looking at the pathway and thinking about how, rather than it being a diagnosis of exclusion, we move that discussion straight to the CUP MDT, rather it being then the last MDT. In advising specialist investigations, we also have the challenge of how we access investigations such as whole genome sequencing. And again, I'll touch on this a little bit later, but this is a relatively new challenge that we need to address. But it all has a knock-on effect on terms of what treatment options we've got for our patients, access to clinical trials and research. And the experience generally for patients is obviously a very difficult experience, and often they won't get the support they need, perhaps through the pathway. There may be delay to palliative care services, and then eventually, if the patient reaches end of life, that sometimes is perhaps unplanned with not the right support in place, and is unsatisfactory, I think, for patients, families, and all the clinicians involved. So, as I said, already we're trying to hopefully, already we have addressed some of these issues, but are also working on some of these areas, but there's certainly lots of room for improvement. So next slide, please. So firstly, touching, I guess, at the first part of that pathway in terms of diagnostics, and what have we done, I suppose, to improve that. So in the last couple of years, NHS England put forward a proposal for implementation of rapid diagnostic centres to be implemented by 2019-2020. So COVID has had some impact on this, but I think most places now are in the process or have already developed their rapid diagnostic centres. And these essentially were developed based on some pilot projects that ran within England called the ACE pilots. And these actually were pathways that were developed for vague symptoms, but we've kind of piggybacked on MUO and CUP onto this because it provides a definite benefit for our patients in terms of accessing early diagnostics. So it provides a route of referral for patients where they perhaps do not fit a standard 2-week wait pathway. When you look at the data, only about 40% of patients who are diagnosed with cancer actually come via 2-week wait pathways. Most patients will either come through outpatient clinics or smaller proportion of patients generally present through emergency departments. But then when you look at CUP patients, it's about 56% of patients that will present through an emergency department. And we know that for all cancer patients, if they present by the emergency route, their outcomes are worse. So it's important, particularly for our CUP patients, that we change this trend. We get these patients identified earlier onto a diagnostic pathway so that they can be managed more appropriately and hopefully improve that patient experience and pathway for them. On the ACE pilots, it was a cancer diagnosis conversion rate of about 8%, but bearing in mind that's in patients presenting with vague symptoms, not just MUO patients. And about 50% of those patients on these pathways actually received a non-cancer diagnosis. So the vision with a rapid diagnostic centres, again, is to provide a single point of access to a diagnostic pathway for all patients with symptoms that might indicate cancer. And we can use these pathways to help in the diagnostic pathway of MUO and CUP patients. They provide a more personalised and accurate rapid diagnostic process for patients and enable us to access some clinical expertise locally and enable us to be able to get the patient to, I suppose, answers earlier on in their patient pathway. Next slide, please. So this is sort of an example, I suppose, of what a pathway might look like during a rapid diagnostic centre. Patients are referred in, maybe from primary care or secondary care. Some investigations can be done prior to referral, like simple blood tests, but they are then seen and have usually imaging performed within the first week, which is usually hot reported. That can then be discussed at MDT meeting, and patients can then be referred on to the most appropriate either site-specific pathway or to a non-cancer pathway if that's appropriate. It hopefully helps to reduce the unwarranted variation that we have in access and will improve the reliability of our diagnostic tests. And again, just improves patient experience because there's a coordinated approach in that diagnostic care. Next slide, please. So what does this look like locally for me? Well, for our patients, when they're presenting as MUO, so as a malignancy of undefined origin, they usually come through 2 weeks. They have a primary care or secondary care. We can now ideally refer them into the rapid diagnostic centres, and when doing that, they will have initial investigations done. Now, for a proportion, as I say, they may be non-malignant and therefore might be referred back to either to primary care or to whichever the appropriate speciality is. For the provisional CUPs, we can then direct them through the local CUP MDTs. And obviously, if a primary is identified, they can go to the correct site-specific MDT. For the patients coming through the CUP MDT, we can then advise on those investigations, more specific investigations, but importantly, I'd provide support for patients, advise on symptom control, improve communication, and for those patients with poor performance status, make early management decisions in terms of whether to continue investigation is appropriate, and referring them to palliative care services. Next slide, please. So just some data just to kind of give a flavour for what that might look like. So this is data from the Manchester Royal Infirmary, which is where I sit on the CUP MDT. And this gives data over a 12-month period from 2020 to 21. So obviously this was during COVID, so our numbers probably were down slightly. But we saw about 86 patients come through our MDT. Of them, 35% had no cancer. So they were actually referred as an MUO, but on investigation, cancer was excluded. Just over half the patients were found to have cancer, but it was a primary site identified. So they then went on to be treated by the site-specific teams. Most commonly, these were lung cancer patients, followed by haematology patients, and then HPB with a smattering of other kind of malignancies also identified. 9% of the patients remained as MUO. So for these patients, either it was felt that they were not fit enough or not appropriate for further investigation, usually due to a poor performance status, or the patient may have decided they didn't want any further investigation, and therefore they were referred for best supportive care with palliative care team. Of the patients, we had 2% which were actually identified and confirmed as a CUP, and they were referred on to the cancer centre here at the Christie for ongoing management. Next slide. Excuse me. So sort of looking at it from the cancer centre's perspective, what do we see here? So as my role, I also sit on the MDT here at the Christie. And we again audited the patients that came through our MDT. This was over a longer period of time, over approximately 4 years, and we discussed about 360 patients at our MDT. And of them, just over 50% were confirmed CUP diagnosis. So even those patients have been through other MDTs before they came to us, we still review them and we look at their cases in a specialist MDT. And this just gives the rationale for that. Because when we look at the data, we can see that it's just under a quarter of the patients that we reviewed on the specialist MDT, we actually did go on to confirm a site-specific diagnosis. And again, we referred them on to the site-specific team. But then a further quarter, we felt there was a presumed site-specific diagnosis. So those are ones where we thought were most likely to be something, although we couldn't perhaps confirm it 100%. And this is important, and I'll explain why in the next slide. So if we can just go on to the next slide, please. So this shows the outcomes for our patients, and this is comparing those groups of patients. So essentially for patients who have confirmed CUP, when we compare their survival to patients where we then found a confirmed primary, you can see that there's a significant difference in terms of overall survival. So if we confirm a primary, those patients do better. For those patients, even where we do a presumed primary diagnosis, again, we see an improvement if we treat them as the presumed primary. So again, it's very important that we can select these patients out, identify them, and treat them accordingly. Next slide, please. So what happens essentially then if a patient is referred to us here at the Christie as a specialist centre? So if they're referred to us, we discuss all patients in our central MDT, so that's both radiology and pathology review. We do that before we see the patient, and usually we see patients within at least 1 to 2 weeks of referral, so hopefully it doesn't cause significant problems in terms of time frames. For those patients who fall into the unfavourable prognosis group, they are referred on for supportive care. They still may be eligible for some palliative treatments like radiotherapy, so we still see them, assess them, and determine what may be suitable for management for them. And they may continue under our care for our review. We could have a discussion with the patient on a patient-by-patient basis to decide how they want their future management to take place. In terms of the favourable prognosis patients, we also look to clinical trials. So for those patients, we also have Cupisco open here at the Christie, which Alwin has already just discussed. But we can also access translational studies such as CUP-COMP, which is an in-house study which allows us to access molecular profiling. This is done through our early phase clinical trials team, which we can also refer to for clinical trials for patients, perhaps if they've had previous lines of chemotherapy. Our standard of care is changing and evolving. We've touched on whole genome sequencing, and I will come on to that just briefly in a moment. But generally, standard of care if patients aren't entering onto clinical trials is combination chemotherapy if patients are fit enough. But again, it's selecting out those patients where perhaps surgery is appropriate or referral for radiotherapy, or where we can identify these specific groups, referring on for those appropriate treatments as per those standards. Next slide, please. So genomic whole genome sequencing is something that is relatively new here in England. It's just been approved really in the last 6 months for CUP patients. So we're still coming to terms, I suppose, of how we're going to be able to offer this and how that needs to be introduced into our standard of care and at what time point. And I'm not sure we've really quite got to the point where we are in the Netherlands, but we really need to be moving forward on this and having these discussions. So I suppose we have 2 options or 2 ways in which we may approach this. One is, do you introduce it earlier on in the pathway? The difficulty with that is the logistics involved in it, because it would need to be done through the the rapid diagnostic centres or through the DGHs, which is going to be very challenging for him perhaps to get fresh frozen samples and the logistics behind that. There's also a risk there. We might be getting samples on patients who are not fit for treatment if that's happening prior to the MDT discussions. The alternative might be to do it later on the pathway following that CUP MDT discussion, with samples perhaps coordinated and collected centrally. But the risk with this is that it might require repeat biopsies for patients, as patients often had initial biopsies performed before they are referred into us. it potentially causes delay in that patient's management. Liquid biopsies may actually provide a solution for this, but at the moment, obviously, that's not something that we can access outside the trial setting. So we've got a lot of work to do in terms of this area about how we're going to deliver this, and this is currently ongoing. Next slide, please.
Claire, in the interest of time, can we ask you to wrap up as well, so we have
Of course,
some time?
yeah. I think this is my last slide, so it's just last bit, just about accessing targeted therapy. So in terms of targeted therapy, really, how do we manage that and how do we access it? Well, really, at the moment, that's through clinical trials or compassionate access schemes. For patients who are good performance status, obviously that's great if we can get them onto clinical trials, but for many of our CUP patients, that's not an option. I'll just mention that in the UK, we will be having the Determine trial opening, which will aim to match patients based on their profiling results to types of treatments which are already licensed in certain types of cancer, and it's exploring a wider, enabling access to a wider range of patients, so hopefully give better access for CUP patients to these drugs. And I think my final slide is just the conclusions. So I think, as already said, it's quite challenging, but I really think the key thing from my perspective is just ensuring that CUP is represented in broader discussions in England and the UK when we're talking about healthcare strategy in the future in terms of diagnostics, treatments and research. I think we've got some work to be done, but we are making some headway on this. Thank you.
Thank you very much, Claire. Interesting how you highlight how the local pathway could influence the national debate on the right model. So now that we have heard all three of our speakers, I would like to welcome them back to the stage for the Q&A. And of course, a kind reminder, please send in your questions. And if we don't have time to answer them today, we will get them to the speakers and we'll get your answers back to you. So maybe let's start with a question for Marieke. And I see two questions that I might want to combine. So the first one would be, with whole genome sequencing, how many primary tumors do you identify? And I think you mentioned in your presentation that it's still too early to tell on the impact and the benefits. Perhaps you could talk a bit about what sort of outcomes you would be looking to report on. Is that only how many patients you can identify, or also maybe quality of life measures?
Thank you, Juanita. Yeah, what I think we should all realize is that what happened in the Netherlands is sort of also for us unique. So the new techniques preceded the evidence. So if normally we're like, okay, this is what came out of a trial, and now we're going to do it like that, and now we change it around. Maybe because of the high need and the report that came out. So those answers are the one that we're seeking. In that IMPRESS paper that I told you about, we see that you can identify with that new CUP analysis, and that's in a small number of patients, but between 60 and 70% of the patients get a primary tumor identified out of the whole genome sequencing analysis. If I look to, we have had this pathway going on in our own cancer institute for the last year. We see between 100 and 150 of these patients each year. And what we see is that actually when you do the revision of the pathology and somebody looks with a new perspective, then almost half of the patients don't need whole genome sequencing because we identify a primary tumor with the normal diagnostics. And then, of course, a lot of people also are in a too bad performance status to actually proceed to whole genome diagnostics. And what Claire also said is, what should you do? Because we actually do quite a lot of new biopsies for these. And what we would like to go towards too, and that's the luxury that we had, is we had a whole genome sequencing trial going on in the whole of the Netherlands. So a lot of the logistics for that is already present in our surrounding hospitals. So what we would like to move forward to is that as soon as you take a biopsy because you think you have a patient with CUP, you take an extra biopsy, put it in the freezer, wait until you have discussed whether a whole genome sequencing is indicated, then send out the whole the fresh frozen tissue to our whole genome sequencing facilities and send the patient to the CUP center at the same time and winning time with that. Are we there yet? No, absolutely not. No.
Okay, and then for Alwin, a first question, then one came in. What are the options to have NGS done outside of clinical trials in Germany?
Okay, so I tried to present that. There are several ones, but very much dependent on the place where you are. So if you are in Baden-Württemberg, there are 4 universities actually that offer free sequencing to patients, not only with CUP, but also with other tumor types. If you are outside of Baden-Württemberg, this is a bit more difficult, but there is also the option, and we offer that, to have tissue, paraffin-embedded tissue sent to us, and then we do the sequencing remote without even having seen the patient. So patients who are at least aware of the option that sequencing is available somewhere in Germany get sequencing right now, no question on that.
All right, thank you. And a second question to you. Will the updated CUP clinical guidelines be helpful to CUP patients?
Oh, we think so very much, for 2 reasons. So it's helpful to the patient. So either you have the diagnosis of CUP or you don't in the first place, which is important. Second, there is a subclassification that helps on discriminating better between unfavorable CUP that is right now treated with next generation sequencing and targeted treatment outside of enough knowledge, I have to admit, or whether you belong to one of the favorable subsets where the treatment is different on the first place. And second, it also helps to make, and I alluded to that, to make the populations of clinical trials on CUP more homogeneous, and therefore make the results of the trial more relevant to CUP patients in the end. So in every respect, I think the classification will be helpful in the end to better treat and diagnose patients with CUP.
All right, thank you. And Claire, a question for you. What has been your experience in accessing drugs through compassionate schemes, access schemes for patients?
So far, it's been very positive, I have to say. I think the numbers are very small in that a lot of patients, unfortunately, just not well enough. Usually they've had previous lines of treatment. So, it is small numbers, but I think certainly it's been aided by Capisco. That's been helpful, certainly in accessing immunotherapy for our patients who have high tumor mutational burden. So it's certainly a way that we can do it, but it would be nice perhaps for it not to have to go through that process. But it's not a lengthy procedure. We've generally been supported by pharma and also by the trust when we've done it, and we've managed to treat now several patients through that route.
Okay, thank you. And I think touching upon what you were saying, and for us as CUP patient advocates, we always advocate for also the access to palliative care, because you all 3 mentioned some of the patients are already, though they don't have the performance status to undergo advanced diagnostics. So what are your views on maybe combining the palliative route as well as the diagnostics route, or should they be following each other? And an open question, so anyone can answer.
I mean, I don't mind commenting sort of from here. I think from our perspective, because our guidance really says palliative care should be embedded in our MDTs, those patients should be linked in literally from the point of diagnosis. And I think that's really key, in able to support patients and to make sure their symptoms are controlled, because that has such an impact on them whether they're actually able to then receive systemic therapy. So I think they need access, at that point of diagnosis would be when I would want them to be involved.
And also another important issue that we also think about here that is important also for in order to save money on that. So it does only make sense to do next generation sequencing on patient samples from patients that are able to tolerate a given treatment after this has been done. So if one can foresee that this doesn't make sense, then it's better to stop, also for the patient, him or herself, but also in order to save money on that for other sequencing efforts.
Okay, thank you. Looking at the clock, this is all that we had time for today, so we will get your answers or your questions answered later on. And I would like to say a huge thank you to our panel of speakers today. We've learned a lot, and I think it's very interesting to see the different approaches among countries, and I hope this inspires new pathways in other countries as well as guideline setting. Over to you, Sarah.
Thank you, Anita, and thank you to Marieke, Alwin and Claire for such a fascinating webinar.